All right, so you're lucky enough now. So we got very lucky at BAMC and have 3 incredible colorectal surgeons, and one of them is Dr. Murphy over here, and she's going to be giving a talk on the surgical management of IBD.
Nice. Hey guys, I'm going to try to distill what I know into 30 minutes. That's things that I've asked my friends what they would want to know from a surgical perspective. And the other thing to reiterate what Dr. Watt said is please text your colorectal surgeons. We're like the happiest surgeons. That's why I went into this field. Please negate what you've experienced in residency. We're miserable. Probably you guys were too. And there's a reason why you picked this field. It's fun. So people are happy to get consults, and the earlier the consult, the better, because it gives us a chance to really discuss with the patient about surgery, which is life-altering. The more discussion you have, the more they understand. So text us. We text all the time. I text him. He also doesn't respond to me, so I'm just kidding. All right, so I'll get started. So just going to go over a quick outline of what we're going to go through. Background, some surgical considerations just in general, especially with IBD patients, when to consult us, Crohn's disease versus ulcerative colitis on specific surgeries, which can get complex, and then ostomies in general. We thought it might be useful to kind of go over what the different kind of ostomies that we make and what that means for you, particularly for scoping. So for some background on operative indications in general in IBD, can kind of bucket them into emergent and then non-emergent urgent. So those emergencies that you know we're going to get consulted on are bowel perforation, obstructions, toxic colitis, which is those with sepsis, and you usually have a dilation over 6 centimeters in your colon. There's megacolon, bleeding, and then of course failed medical therapy, which you have the acute severe ulcerative colitis in the hospital, which we usually get consulted on. Then you have urgent non-emergent, where you're treating these patients, you're going through the list of medications that you have. There's so many now, but those who are failing medical therapy, good to get them to us. Those that have penetrating disease or fistulizing disease, and those with cancer and dysplasia. I cannot talk about cancer and dysplasia in this talk. It's a lot, but we'll go on a few slides of general things to think about for colectomies in these patients, but obviously they're higher risk for cancer and dysplasia, so another indication for surgery. So it's oversimplified. I'm going to keep it oversimplified, but think the thing that's hard for us, especially for patients who get diagnosed with UC and then transition to Crohn's disease, that's hard to lose your whole colon and then go through complications from a pouch surgery to then ongoing issues when you thought you could cure them. But there's about that 15 to 20% crossover, especially after colectomies for people who thought they had UC and then it comes to Crohn's. So we all know it's oversimplified. The diagnosis changed, but for the nature of this presentation, we're going to try to bucket these two. Crohn's disease, no surgical cure, but the goals of those cure are going to be specifically to relieve their symptoms, preserve the small bowel as much as possible, and then minimize the treatment interruptions that your gastroenterologist, you guys, are going to be giving to them. We want to get them back on those medications. For ulcerative colitis, it is surgically curable, with caveat of obviously there's going to be some crossover afterwards. It can be. But the goals of surgical care are going to be maintain functional outcomes, and specifically going to talk about bowel, sexual, and urinary dysfunction that can happen both from chronic inflammation and surgery itself. And then finally, we really try to treat the patient, not the disease. Everybody's different. They come in with different issues. People who I've had chronically or usually in fellowship, we don't offer them ostomies immediately. A lot of times they want it by the time they're done with like certain kind of fistulas. So it all depends on what we offer them with what they want. And something I like to think about, I don't tell patients this, but something I like you guys to know what we're coming from. Crohn's is really just palliating people because of the chronic disease process. Everybody's gonna be different, but just like medications, we're just trying to get them through to have a good life. All right, so in general, surgical considerations when we think about IBD and Crohn's and things that were touched on by Dr. Thomas as well, is that smoking cessation, yes, while it's protective for UC, it can be a harbinger of pulmonary complications, infectious complications, and anastomotic complications in our surgical patients. So in addition to weight loss, smoking cessation is huge, and not just like right before surgery. It's actually protective. If I'd rather have somebody smoking right up until, instead of doing it like 4 or 2 weeks afterwards, because they can have actually horrible pulmonary complications, and everything I say with caveat. I just want nobody to smoke. That would be great. But 8 weeks is the best time because then they have less mucus production. It's better for the anesthesia, better postoperative care from pulmonary standpoint. Weight loss, we're going to be dealing with nutrition and weight loss a lot and what malnutrition is. I mean, you can have somebody who's overweight but malnourished. And so when we want weight loss, we want it in the good way. So if they have, if they could lose weight, if they are not malnourished, that is ideal because that can affect pouch surgery particularly. And that can be something you can educate a patient on working towards for their end goal if they have UC and they're failing medical management. So nutrition is an independent risk factor for morbidity and mortality of surgery, and obviously for medical treatment of these two as well. It's irrespective of the immunosuppression and biological therapies that they get, and it's something that we can help change, especially if somebody's coming in non-emergent. So we've seen, particularly in pediatrics, that exclusive enteral nutrition is very helpful and can lead to cure more so than, or better than steroids. It's not proven in adult population, but it can still be very efficacious. And so we've had patients in my residency and fellowship program where we had somebody coming in with a BMI of 16, and we actually put them on TPN and an NG tube, got them to gain weight over 20 pounds over 3 months, and then got them to a safer surgery, got them off steroids, and that way they could have a surgery without an ostomy. So there's some time on this spectrum for colorectal surgery that we can really hopefully get them to an ostomy-free surgery. Goal that I like to set, and this is what I always check and have my residents check, is that we always get an albumin and pre-albumin. You're going to get your whole host of labs, CRP, ESR, I know we've gone over that. But anybody below an albumin of 2.5 is likely not going to get an anastomosis, depending on where we are in the GI tract. I also want to get pre-albumin. We have to be careful of both of these things because they can be affected by inflammation and acute phase reactants, but by and large, these are helpful parameters for your surgeon, and these are things I will always check if you consult us. Steroids. So there's a dose-dependent relationship, obviously, between the use and their complications. And the highest risk is anybody over 40 milligrams of prednisolone or its equivalent per day. If we can get them into an elective and semi-elective position, the goal is to wean off their steroids for at least a week. If we can do it longer, that would be great, because again, less chance of infection complications. And if your complete cessation is not possible, which we know it's not in everybody, trying to get it below 20 milligrams of prednisolone or its equivalent is great, especially depending on where you are in the GI tract. For ileal Crohn's, I would consider not giving them an ostomy if they're on less than 20 a day, depending on how long they've been on it. If somebody's coming in with 3 months of prednisone, probably not, but something to keep in mind for us. And just for kind of clarification on when we say like steroid dependent versus refractory, refractory really just refers to those who have active disease despite prednisolone up to 1 mg per kg per day for a period of 4 weeks. And those who are steroid dependent, who are those unable to reduce their steroid dose below the equivalent of 10 mg per day without disease reactivation or have had a relapse within 3 months of stopping steroids. So this is something I kind of always make note of when I see our patients, either inpatient or outpatient. All right, this is a big one. So immunomodulators, doesn't matter. So methotrexate, AZA, it actually doesn't increase complication rate. So we usually just hold it the day of surgery and resume it afterwards after we have a discussion with our gastroenterologist. If we have a little bit of time, we might hold it a few more days, but it really doesn't matter. So holding it before is going to be fine. Biologics, so specifically anti-TNF, and I don't have a lot of data on some of the newer medications because you guys are like, it's a lot, it's amazing. We have new stuff coming out for our patients, but the most studied are anti-TNF agents and some of the antibodies. So we have a lot of studies, complicated by drug pharmacokinetics and drug levels, so it's kind of hard to interpret. And then the complications don't always appear to correlate with anti-TNF alpha, like serum levels, and then that's also hard to check. So like all these studies, it's just a lot. So we've had a couple of kind kind of large retrospective studies. We had one that was like over 500 patients. Like, if you had TNF alpha medications or anti-TNF alpha medications within 3 months, you had an increased risk of infection and postoperative complications. We had another one that was out of France. It was over 7,000 patients, showed the same thing. And then you've all heard of the Puccini trial in 2022, and it's kind of our best data, and it shows that any anti-TNF within 12 weeks of surgery actually doesn't increase complications. It's all over the place, but in general, if we have an option, we like to hold it for like 2 half-lives of the drug. But if somebody's inpatient and emergent, it doesn't really change my operative technique. All things that really change my idea of surgery for ostomy versus an anastomosis for these patients is if how nourished they are and if they're on steroids. I really don't base it on their last dose of any kind of biologic. If I'm in an elective setting, it would be nice to hold it for 1 dose though. So that's kind of general rule. Now let's talk about vedolizumab. So there's conflicting data and they're low volume studies. It remains controversial, but we like to hold 1 dose prior in general, and hopefully that can be done. Same, first, yeah, I have to say USA too. Limited data does not appear to increase that risk, and so we don't really hold it either. So, yeah, in general, don't recommend to delay surgery due to these alone. All right, the other thing that I can't kind of harp on enough, and we've been very lucky at BAMC to have very good endostomal therapists here, but if you are thinking that your patient might need a stoma in the future for various reasons, somebody I talk to a lot and we have in our office are endostomal therapists who can mark our patient prior and then also talk to your patient about education, because the more they know, the less scary it is, and they can also really understand that sometimes it's not permanent, which is really nice for them to know. All right, and then when to consult us. Really, anytime. I love texts. I love getting the text. I have somebody in the hospital. Would you like to meet them? I'm like, yes, I'd rather meet them and not have to perform surgery and have them meet me a couple times. It builds trust. I also don't mind getting consulted emergently, but really you can text anytime. What I like to counsel patients on, we have some different data a long time ago, back in the 90s. We had data showing up to 60% of patients needed some kind of surgical intervention for Crohn's disease in their lifetime. It's kind of gone down with all the medications that we have available, so I'm sure we'll have some more data coming out that it might be lower. But in general, I say for both Crohn's and UC, when I talk to patients, you might need a surgery at some point in your life. Up to 30% of patients need it. Crohn's disease, up to 15% at 1 year after diagnosis, 25% at 5 years, and up to 30% at 7 years after diagnosis. And then ulcerative colitis, about 10% require emergent surgery, but most of them are dealt with in an outpatient manner, which is great. And then here are kind of some broad recommendations of inpatient versus outpatient consultation for surgery. Patients admitted on IV steroids probably should start be thinking about, for IBD specifically, thinking about surgery and getting them involved. Anybody getting infliximab inpatient, and then any acute issues, obviously perforation, acute blood loss, anemia, and obstruction, things to let us know about. Outpatient's a little different and kind of a nice nuanced discussion between your surgeon and you. So it's just patients who have had multiple tapers should probably start thinking long-term where their disease process is and if they might need a resection, getting them sent to us. Those on dual therapy, or you're having multiple, like maybe biologics more so, is what I mean by dual therapy, and overall failing medical management, which can be very broad. And then the chronic symptoms, people who are losing weight, like 10 to 20 pounds over the past 3 months, people who are anemic, and those who have obstructive symptoms definitely need to come talk to us. And again, just earlier is better. All right, we'll go through some Crohn's disease. This is kind of broad. I'm gonna focus on these main ones here because they're some of the more common ones that we'll see. Perforation and bleeding, kind of rare actually, and these are the most common that we get consulted on. So bowel obstruction, the most common area for Crohn's is going to be the terminal ileum. And like remarked on before, you really need to designate the difference between an inflammatory stenosis and a fibrotic stenosis. Inflammatory medical treatment is going to be key. Your MREs are going to be really helpful for this. Sometimes you can't always have a slam dunk diagnosis, and so your colonoscopy, endoscopy is going to be very helpful too. But for fibrotic ones, for these really just burnt out terminal ileum, it's really not going to be helped unless you do something mechanically to it. So this is where you guys come in, advanced GI, you guys can do endoscopic treatments. Those are the best for the short term or the short length ones for less than 4 centimeters. That's usually our cutoff. You really want to get that diameter at least of 14 millimeters, and there really shouldn't be any kind of angulation or fistula that's seen on the MRI for this to be appropriate. Anastomotic strictures are really good for interventional GI as well, and can be very helpful. When we start thinking about surgery, we think about multifocal or those fibrotic areas. Really just need to remove it and put it back together. All right, some pictures. Fistula, about 11 to 16% of patients have penetrating intestinal disease manifestations. The most common is going to be enterocolonic, about 30%, followed by enteroenteric, and then enterocutaneous, about 20% each. The rectovaginal fistulas and enterovesical fistulas, so that to your bladder, are pretty rare, and those are incredibly symptomatic, but usually not seen very often. And then very rarely do you have it to the stomach or to the salpinx. Only fistulas that are symptomatic really need to be operated on. So if you see something on CT MRI and they're fine, you can talk to your surgeon. We'd love to see them, but you do not have to do anything unless they're having symptoms. And it'd be helpful if you could also surveil that area, either with like capsule endoscopy or colonoscopy, but you really don't have to do anything. Abscesses, very common. What's very helpful is the IR. Just like everything's advancing, it has revolutionized surgery. It's making it safer and getting people not to have surgery. So if it's over 3 centimeters, getting an IR drain is great, and you can get up to 30% of patients that can avoid surgery altogether. But they have a lot of postoperative septic complications if this fails, just by the nature of abscesses. So definitely try IR first before, or this is where we come in, but we would suggest that first before taking somebody for an exploratory laparotomy, just for an abscess. So, and again, these abscesses are associated with just poor complications in general, sepsis, stomas, and infections. Okay. Ileocolic resections for us, we've had some good studies. We don't have to, just like the name of the game is palliation, we want to leave a lot behind. And we don't have to resect to grossly positive, like, or microscopic negative disease. We just have to grossly negative disease. So when we're in there and feeling around, and we also encourage you to come to the OR if you want. It's fun to have other people. We're tired of our team. We love people to come in and scrub in, like, please do, and like feel the bowel, because it dictates what we do, and you can kind of see how we make some decisions. But we resect what looks diseased and put it back together. The type of resection you're going to get and then scope afterwards is going to be dependent on your surgeon, and there's no randomized data to show one anastomosis is better. So just to kind of go over some of the anastomosis we do and what you might see in some operative reports. The side to side is the most common because it's just ergonomically easier for us to do. It's very quick, and that's that one on A. Yeah, that's side to side, and we say anti-peristaltics because you have 2 ends going up and then back. So if you see that on the op report, that's what that means. We can also do side to side isoperistaltic, so everything's flowing in the same direction. You have end to end right here, and then you have a side end there. I'll go over another one too. There's a Cono S anastomosis that's a little newer. The data, we'll go over that. But by and large, we want to make a wider anastomosis, particularly if this is stricturing disease process. But we don't really have any data to show that one is better than the other, because a lot of them do remark on endoscopic recurrence, but sometimes we're like, does that make a big difference if they're not symptomatic? Kind of have a discussion with a gastroenterologist about that, but we try to make it the wider the better. Strictures, again with Crohn's, we try to preserve bowel. So if somebody's had multiple bowel resections, we will do stricturoplasties, and this is just what this means, is that we take a piece, we open it, and just make it wider. We will biopsy these areas because up to 6% can have an underlying dysplasia or cancer, and that's particularly the case for large bowel. So for large bowel, we don't really do these strictureplasties. These are just for small bowel disease. Large bowel, we will remove it, and depending on where the how inflamed and their disease process is, they get an ostomy or a connection. So those are just different types. This is the Crohn-S. It's all it is showing a very wide anastomosis. It takes a little bit longer. I think in people who do it very often, it's just as quick. In their own data, in about like 60, 70 patients, they had a lower probability of anastomotic surgical recurrence in the Crohn-S group. And it makes it a little easier for your colleagues or you guys to scope it because you're not trying to go around a bend. But anyway, I'm not sure that it really does much for recurrence. I think it's to be determined. But if you see this on the op report, this is what a Crohn-S means. It's just a different way to put it together and make it a very wide and very straight connection. All right, disease recurrence after an ileocolic resection. Crohn's disease can be up to 70 to 90% on endoscopy at 1 year, and up to 30% of those patients may require an additional operation within 5 years. This data is going to change as all of these new medications just get better and better. But when somebody asks me, like, what's the likelihood of me needing surgery, and if they get fibrotic disease, like, you'll probably need a surgery by the time you're 50, and I just tell them up to 30% of patients with Crohn's need surgery. The other thing we can do, people aren't fond of this one, but we can use it in some very, I guess, like a bomb of an abdomen is how we would describe it. Somebody comes in really sick, there's a lot of abscesses, it makes surgery very difficult, and resection, you tear a lot of things. We can fecally divert them temporarily and cool them off, and then compare it, or basically work with you guys for the different medications that they need. It might make the subsequent surgery less extensive, and then relapse rates, unfortunately, are as high as 33%, because usually when you do these, you're diverting from a very bad issue anyway, so sometimes you just can't prevent the complication of abscesses and fistulas. But yeah, ultimately not what you take out, but what you leave behind, so we really like to conserve as much as we can. And now, transitioning to ulcerative colitis, and we can talk about ileoanal pouch anastomoses, et cetera. So indications, elective, so approximately 30% again will undergo surgery in their lifetime. And then the medically refractory colitis, it's about 70% of that surgical cohort instead of the emergent. This is for colorectal cancer, high-grade dysplasia, and multifocal low-grade dysplasia, also options for elective surgery. And usually when we're talking for patients diagnosed with UC, we're talking about a total proctocolectomy, which means getting all the colon out and the rectum. For emergent, and this is something we see each other a lot of inpatient, as are these acute severe ulcerative colitis patients, so they're like not immediately sick, but could get very sick, who aren't responding to medical therapy, those in sepsis, toxic megacolon, perforation, and severe bleeding. The only slide I'm going to put on this, because I'm not going to lie, you guys have been revolutionary in this and help us, so our guidelines are probably like 2 to 5 years behind yours, but this is a nuanced multidisciplinary conversation. Depending on the resources you have at your facility, if what kind of endoscopy do they do, chromoendoscopy, how they like to do random biopsies or targeted, but essentially visible dysplasia not amenable to endoscopic excision, they are a surgical candidate. Invisible dysplasia in the flat mucosa surrounding a visible dysplastic lesion, also a candidate. And confluent inflammatory pseudopolyposis, if that interferes with the ability for you to do surveillance colonoscopy, also a candidate. And then colorectal adenocarcinoma. This can get a little tricky when we talk about rectal versus colon, and so there are a few things that we can do differently. But absolutely all of these would be an indication for a total proctocolectomy. All right. Surgical approach versus emergent. In the elective setting, we can do a multiple stage. It's very rare to do one stage, but it's usually 2 or 3 stage ileoanal pouch anastomosis after we remove the rectum and the colon. And in the emergent stage, we do a total abdominoplectomy with endoleostomy. And it took me a while to really understand why we leave the rectum, and I kind of really want you to know why we just don't do it then. They're usually sicker at that time, obviously, when we're doing this emergent case. And a proctectomy adds up 2 to 3 hours to the case. So we want to get them off the table sooner. It also increases our risk for any kind of autonomic or sympathetic nerve dysfunction. So they can have higher rates of erectile dysfunction, sexual dysfunction, urinary dysfunction if we do a proctectomy in the emergent setting. So we leave it alone. Additionally, when you remove the rectum, you have to put something there to fill that space. And so the only time we do it is when we're ready to do a final definitive like a reconnection, or if they're saying, hey, I don't want a pouch because it has its own set of woes, then we do the definitive because it fills with a lot of small bowel, a lot of adhesions. It's like you only have one shot at the pelvis and you want to make it worth it. So bleeding can be really hard when you have medically refractory people who are really sick in the hospital with UC. And so the goal, by doing a TAC, we keep the rectum in place. People get better magically, beautifully. They get off of steroids. That's our goal. We want them to get out of the hospital. We want them to get them nutritionally replete. And then we want to get them optimized. And you can wait on this patient, or we can, for a year, 3 months. It depends on how well they do. But if we want to give them the best chance of healing and anastomosis, then we got to get them off the medications they came in with. Reconstruction is patient-specific. So when I see people, especially women who have had multiple kids, or if they haven't had kids, this kind of discussion is very important for us, talking about fertility, because once you operate in the pelvis, you create a lot of scar tissue. And while it doesn't affect, it's really fecundity, but it's affecting the travel of those eggs, essentially through the pelvis to the fallopian tube. So it's really dependent on the person, and some people are incontinent or have issues with incontinence. Most of that gets better once you treat the UC, but some people just aren't interested in pooping their pants, and so they want the ileostomy or some kind of stoma. So kind of going over this briefly, we can go into 1, 2, or 3 stages of the IPAA. Again, you got to assess the integrity of the anal sphincter before you offer this, but by and far, surgeons should be doing this laparoscopically. Gets people home faster and less scar tissue. So just some diagrams. So for the total abdominal colectomy, we're going to remove all of the colon, and we're going to leave this rectal stump here, and that's up to 15 centimeters and just stays. And then we give them an end ileostomy. We teach them how to use it. That's where our endostomal therapists are really key. They get them better, get off steroids, get them healthier, and get their nutrition up. Then 6 months later, we take that piece of ileum, and we basically make a little pouch. It's about 15 centimeters of this whole thing going up and down, and just a pouch that can be the new reservoir for the rectum. In the 3rd stage, we then just take down the ostomy. So those are the 3 stages. It can be narrowed to 2 stages, which is the next one. In people who are really, really healthy, people who are coming maybe for a dysplasia diagnosis, who are otherwise not on steroids, it is incredibly rare for people to do a 1 stage, and these would be at like very high volume centers like Cleveland Clinic. And even then, it is the rare patient who gets offered a 1 stage approach. This anastomosis is super high risk. If this leaks and you're not protected, pelvic sepsis can kill the patient, but also ruin your chance for subsequent surgeries and their function in the future. So we take it pretty seriously to divert them and let them know. Usually between stages, you can go anywhere for like as long as you want, but at least 6 weeks. And then considerations, I tell this to all my patients, and this is a conversation you can leave to us, but I say that pouches are a option, but not everybody's option. Some people will try it out and just not want it later in life, and that's okay too, because we have options down the road. But you get about 4 to 8 bowel movements a day, loose stools. There is a chance for pouch failure, regardless of what you do it for. Pouchitis is up to 5 to 35% of patients, and it can be very severely lifestyle limiting. Fertility issues, so it can be up to 26 to 63% of patients. So we usually wait for a proctectomy until after childbearing years for UC patients and some rare Crohn's patients. And then pregnancy after IPA is actually not associated with increased complications to the child or the mother. But when you do have a complication with a pouch, it can be very severe and would need obviously some specialized care. So, and then if done electively, this is also the big thing, no increased risk of erectile dysfunction, which is something we definitely talk to patients about. How much time do I have? Okay. Quick things for end ileostomy and kind of ostomies that we might give your patients. So end just means we have one piece of that bowel coming up to the skin. A loop is really just, it depends on the pathology, but it's kind of for your surgeon too. So a loop makes it very easy to reverse down the line because we can go through this one incision, and because we have both of these pieces here together that we can just take through this local excision, bring it up, anastomose it, drop it back in. It prevents us from having to reopen the patient when you do like an end or going back to reversal. So just something for you to know. Ileorectal anastomosis for ulcerative colitis is actually pretty rare. Pretty rare to have not rare to have rectal sparing, but to not take the rectum, it's a very rare patient who would leave the rectum in place for ulcerative colitis and get an anastomosis. We usually take it all out because it's surgically curable, but if somebody really wants it, it's a discussion piece. Continent ileostomy is incredibly rare. It's a Coke pouch. Again, high volume centers do this. I'm just putting this here because it's complicated to make. I have never made one. I don't want to make one. I think the certain kind of patient this would be helpful for are those who have maybe some incontinence issues but still want to not have a pouch connected to them. So the way this works is they have like basically a nipple valve underneath the skin that they can basically catheterize themselves. When done well, it could work. It works beautifully, but it usually entails at least for one person I know who did these, 1 to 2 operations because a lot of them have complications. All right, and ostomies, just so you know, end versus loop, this is what they look like. And with the loop ileostomies, depending on if we do an ileostomy or colostomy, but the colostomy can be helpful because you can scope from that end. So say somebody has like a really severe stricturing anal disease process like fistulizing, and it's super painful for them. If we gave them a loop, you could still surveil that piece of the colon if they didn't want to get their colon out, or if they still had it by that point. And the different reasons we do it really dictates what kind we give. That's just kind of how we make it. And then we try to give this a nice, I guess, we want this to come about 2 to 3 centimeters off the abdominal wall. It's better to pouch, and it leads to less issues with skin irritation. So we've had patients that have horrible issues with their skin for many reasons. Pouching issues, once it starts, it can really just kind of dovetail into issues around this area, and that's where your endostomal therapists are really helpful. And the other thing for marking, this is why we mark preoperatively, putting a stoma in a skin fold sucks for patients. So this is why it's important to do this before. I'm going to skip this because I think we're coming up on time. Just know it's an entity and about pretty rare, but it is there. So conclusions. About 30% of your IBD patients will need surgery in their lifetime, and then the type of surgery is really is dictated by their diagnosis and health at the time of surgery. Steroid use, malnutrition, and smoking are huge. And then overall, just consult us early, and we love getting consulted. So, yeah.